Hello, everyone, and welcome to Henry Schein's webinar series on COVID-19. I'm Dr. Gary Severance, and it's a pleasure to bring back Dr. David Reznik. We've missed you, Dr. Reznik. Welcome back, and we look forward to all the information you're going to provide on the update to COVID-19.
Thank you, Gary, for the introduction. It's always a pleasure to bring the latest clinical update to the people who watch these webinars. It's been a little bit of time, and we have a lot of information to cover. But I really want to talk about where we are with the disease. I have some excellent news on the lack of transmission in the dental setting, which is really quite wonderful. I have some excellent news to talk about people's willingness to come and see the dentist, which we all know that we want to get our patients back. We want our programs to be at as best capacity as can be under these circumstances. And to get there, let's just do some background on where we are with the disease, where we are with COVID tracker, how many cases are we seeing, and then we'll discuss a little bit about Airborne versus Droplet versus Aerosol, because that does confuse a lot of people, and I thought, let's take the confusion part out. So starting with the COVID US tracker, we have almost 8 million cases in the United States at this point, of which over 2 million, say 600,000 people are active cases. Again, good news, over 5 million people have recovered from this, and they will have some level of antibodies and some level of minor immunity. And we've had sad news, about 2.8% or greater than 218,000 people have died from this pandemic. And for those whose families have been impacted, or neighbors or friends that have impacted, this has been quite a very disturbing time. So we have to look for the bright side of things, and let's get started. But we're still on where this pandemic is. I think the last time that I talked to you, Georgia was getting walloped by COVID. And right now, we're not being walloped by COVID. What we're seeing is that Wisconsin is taking quite the hit these days with over 1,000 cases per day. A dear friend of mine who works in a health department in Wyoming has been dealing with a significant number of cases. And as you know, Wyoming is not one of our larger states and has a lot of wide open spaces. But if you look at the map, and this is actually cases in the last 7 days, you can see that Florida still remains an issue, Texas and California, but we're really having to deal with these Midwestern states. So if you're in a lull, like Georgia is in a lull right now, please make sure you take all your safety precautions when you're in the dental setting and when you're out of the dental setting, because you don't know when it's going to come back. I'm also going to make a plea that people get their flu vaccine. It's very important that you get your flu vaccine this year, like in every year, but even more important this year because the symptoms are similar. So please make sure you get your flu vaccines. So where are we with our cumulative cases? This is a graph showing you that in early March, at that point, our lives were somewhat normal. But then by the middle of March, you can see how the graph took off and the number of cases increased. Then it sort of decreased when we got to May a little bit, and then we had that enormous spike in July, which was quite devastating to most parts of the country. We started to see the cases go down, but what are we seeing now? We're seeing a trickling up of cases across the United States. So it's very important. This pandemic is not over. It's important that we maintain all of our precautions that we've been doing in the past and keep our patients safe. Talking about safety, where are we with the COVID-19 vaccine? If you look internationally, there are 29 vaccines that are testing safety and dosage as in phase 1. We have 14 vaccines who are in expanded safety trials or phase 2. And internationally, we have 11 phase 3 trials that are ongoing. These are large-scale efficacy tests. Regretfully, in the United States, we're looking at 4 major trials that are part of our effort. And J&J, their COVID-19 vaccine trial had to be paused because they had an unintended consequence. It was an unexplained illness. And when that happens, you have a drug safety board who looks at what's going on. And in this case, they decided to halt the trial to do more research to find out why. So please understand, when we do have a vaccine approved, it's going to be going through a very tight, very secure, very detailed process through our FDA, through the companies that are working, through the drug safety monitoring boards that are involved. So right now, the J&J phase 3 clinical trial has been temporarily halted. It is not known if the unidentified illness was related to the vaccine, so that's why they're investigating whatever happened to this individual. And as I said, it's one of 4 large-scale trials that are ongoing in the United States. Another one of our trials, the AstraZeneca trial, was halted on September 8th after a second participant was diagnosed with a neurological condition. So we have 2 of our 4 vaccine candidates on temporary halt. Is this a bad thing? Actually, no. We're looking to make sure that these vaccines, when they are available, are safe and they're effective. And we do want to get to the finish line as soon as possible, but we have to do it as safe as possible. So let's go on to the confusion that exists between aerosol versus airborne versus droplets in relation to COVID-19. I do remember when we first started discussing this at the program I work in, and we were looking at our primary care providers learning how to put on PPE, which, to be frankly honest, was funny that day. They were talking about how COVID-19 was only transmitted through droplets, that we didn't have to worry about aerosol. We all know that that is no longer true, but let's go through some of the different definitions on what we're seeing. Our aerosol is a catch-all term for any solid or liquid particle so small and so lightweight that it can be suspended in air and float. So some examples are smoke and dust. Some viruses can become aerosolized, making airborne transmission possible. And we'll go into a little bit of detail on the different viruses and their different level of contagion. The WHO defines aerosol transmission or airborne transmission as very small droplets that are able to stay suspended in air for long periods of time. So we know that droplets, because we're so used to working with them in dentistry, how that works, but aerosols are a little bit new until recently for us. Airborne is when a droplet containing a virus is small enough to float in the air, and airborne transmission can occur when infectious particles are inhaled by someone else. So you have an infectious particle in the air, so the person is not masked, it gets into their nose, their mouth, or their eyes. The WHO said there is mounting evidence that airborne transmission is possible, mostly indoors in poorly ventilated spaces, because there have been reported outbreaks. And we discussed the choir before, that we had a super spreading event at a choir where one person was infected out of the 60 some odd in there, and 50 some odd people ended up with COVID. We've also had issues in bars and nightclubs and in restaurants, and when it's loud talking or loud singing and things of that sort. Droplets, as we know, are large mucus or saliva particles heavier than air that fall to the ground or end up on our PPE. A droplet transmission typically occurs when droplets containing the virus come in contact with another person's mucous membranes, their eyes, their nose, and their mouth. I think it's very important that we stress that to our patients, that I see so many people who are wearing masks and their nose is out, or they're wearing masks and it's under their chin, or they're wearing masks and they're on their head. So the whole object is just to gently remind people and to stress it, because that is a way of doing a public service. So current evidence suggests that close contact and person-to-person transmission is the primary way that COVID-19 spreads. So aerosol is one way it spreads, but not the primary way. It is that droplet way that I was taught early on in the epidemic, but we have something that makes it special because it can be aerosolized and it can be infectious. The American Dental Association did weigh in on the updates to the CDC webpage, which I will discuss shortly, on how the virus represents an official acknowledgement of growing evidence that under certain conditions, people farther away than 6 feet can become infected by tiny droplets and particles that float in the air, an aerosol, for minutes and hours. And that does play a role in this pandemic. Still, the CDC is primarily saying that it's droplet transmission within 6 feet, not being masked, not taking appropriate precautions when someone sneezes and coughs. And remember, I'm seeing people out there who are going back to the old coughing into their hand, not doing the coughing into their elbow, not making sure that there are tissues at the front desk. We really have to stress this. This has been a long-term battle for us. We saw something new. We've learned how to adjust to it in our clinical settings. I think we've done a marvelous job of adjusting to it in our clinical settings, but we really have to remind people when they're not in the clinic how important it is to do respiratory hygiene, masking, washing your hands on a regular basis. So the CDC did update their coronavirus page. There was a little bit of controversy about that, but we do know that COVID-19 spreads very easily from person to person. That's obvious by the number of people in the United States and around the world who have been infected by this disease. How easily the virus spreads from person to person can vary. The virus that causes COVID-19 spreads more efficiently than influenza. I'm not saying that it's more severe or less severe. It spreads. It's more contagious than influenza, but doesn't spread as efficiently as measles. And so I think that is something important to do. Measles, you can actually walk through a room where somebody has been and they're gone, and you can get measles if you weren't vaccinated. Again, the importance of vaccine for some of these diseases that are out there. So measles is one of the most contagious that are out there. So how do we think it's most commonly spread? I'm going to stress this again. It's when you're physically near someone within 6 feet to a person with COVID and have direct contact with that person who's at greatest risk for the infection. When people with COVID cough, sneeze, sing, talk, or breathe, they produce respiratory droplets. We've shown videos in the past on how those respiratory droplets work and how the aerosols work. The droplets can range in size from larger droplets to smaller droplets. Small droplets can form particles when they dry and then be through airborne transmission. Again, infections occur mainly through exposure to respiratory droplets when the person is in close contact with someone with COVID-19. As the respiratory droplets go further from the person with COVID-19, the concentration of the droplets decreases. Larger droplets will fall out of the air due to gravity. Smaller droplets and particles will spread apart in the air. So again, we're looking at something that I've looked at in HIV for years, which is the viral load. How much viral load is actually contained in an aerosol and how infectious is it? With passing time, the amount of infectious virus and respiratory droplets also decreases. So that's one of the things that we need to know. It's not like measles or TB or things that can stay in the air for minutes to hours. And those viruses, some of these viruses are able to infect people who are further than 6 feet away. So that's airborne transmission, and it's important in a way that things like TB, measles, and chickenpox are spread. Not necessarily COVID, although we do have airborne transmission of COVID. So for some viruses and bacteria, airborne transmission is highly effective. And I'm not saying that about COVID, so I want to be clear. For some, and some of these examples include Mycobacterium tuberculosis or TB, the virus that causes measles, varicella zoster, the virus that causes chickenpox. They are very easily transmitted through airborne transmission. Although these infections can be transmitted at close range, they also are efficiently and frequently transmitted over longer distances, much more than 6 feet, over longer periods of time, as I mentioned earlier. It could be hours when it comes to those highly infectious agents. So we really need to control pathogens that are readily infect by means of airborne transmission in healthcare and occupational settings. And I know that is something we have spent a great deal of time concentrating on. How do we, as dental healthcare workers, make sure that if we do have a patient who is positive, who is asymptomatic, that we don't spread it in the dental setting? And the excellent news is that we don't have any evidence that that has happened at this point. So diseases that spread efficiently through airborne transmission tend to have high attack rates because they can quickly reach and infect many people. So this is, I think, a very settling sign. A significant portion of SARS-CoV-2 infections, about 40 to 45%, occur without symptoms. We know that there's a lot of asymptomatic transmission. That infection can be spread by people showing no infection. So we know, as I just said, you could have asymptomatic infection. You don't know you have the disease, but you can infect others. And we might be treating patients in our dental healthcare settings that are asymptomatic because of all of the steps we have taken. And we'll talk about those in a minute. We are really doing an excellent job as a profession. So the SARS-CoV-2 is primarily airborne transmission. If it were like airborne transmission, like measles or TB, we'd have a much higher infection rate. We have a much higher death rate. So just because if you look at the numbers, really it is droplet transmission, number one, but there is the possibility of airborne transmission as well. Our available data shows that SARS-CoV-2 is spread more likely than other common respiratory infections, such as influenza, through respiratory droplet transmission within 6 feet. There's no evidence of efficient spread to people far away or who enter spaces hours after an infectious person was there, like is the case with TB or some of the other diseases I've talked about. So again, it's not as infectious as some of these other agents. It is infectious more so than the flu, which is why we're looking for our vaccines in the future to protect everyone as much as possible, and all those steps we've taken in the dental setting to ensure we're providing a safe dental visit for all. There are several well-documented examples in which SARS-CoV-2 appears to have been transmitted over distances or times. They're uncommon and typically involve the presence of someone who is infectious, producing respiratory droplets for an extended time. So this is greater than 30 minutes, not the 15 minutes we've been hearing before, and in an enclosed space. Enough virus was present in the space to cause infections to people who were more than 6 feet away or who passed through the space soon after the infectious person had left. Again, so I'm trying to make the difference between something that is highly infectious, like measles, and something that is not as infectious, like flu, and we know how much flu we have. COVID-2 is more infectious than the flu, but not as infectious as others, but in poorly ventilated spaces where they don't have good air transfer rates, and if people are there for an extended period of time, there is the possibility of airborne transmission. So, what are the circumstances when we have airborne transmission? It would be enclosed spaces, prolonged exposure to the respiratory droplets, and inadequate ventilation or air handling. And those are things that our dental offices have really, truly been working on, because we know we're in enclosed spaces, and we know that dental healthcare workers can be exposed for longer periods of time, but that was before we did all this technological advance and did some research into it. We have questions that aren't answered. This is a new disease. As I said, I had infectious disease physicians telling me the only way that this would be transmitted was through droplet. And then now we know that there's airborne transmission or aerosol transmission. We also know that we are great producers of aerosols in small spaces for our patients. So what are some of the questions that we don't know? How effective are mitigation efforts to prevent SARS-CoV-2 spread, especially with ventilation and masking? What proportion of SARS-CoV-2 infections are acquired through airborne transmission? We actually don't know. We think it's a smaller amount. We know it's possible, but we don't have any data on it. What are the conditions that facilitate airborne transmission? We do know that bad ventilation, closed spaces, infectious person, but we really don't have everything documented at this point. What is the infectious dose of SARS-CoV-2? So this has to do with viral load, how much virus is present for there to be effective transmission. Do inoculate size and route of inoculation affect the risk of infection and disease severity? So how much virus you're exposed to doesn't mean you'll be sicker, or does that have to do more with your underlying medical conditions, the comorbidities that we hear so much about? So there are a lot of questions about this, but we as a profession have done a lot to answer some of our infection control concerns. And as you know, when you're in the dental setting, pathogens that are easily spread through airborne transmission requires special engineering to prevent infections. I think we all have been pretty much schooled on that. Control practices, including recommendations for patient placement and personal protective equipment for healthcare personnel, can be found in the interim infection prevention control guidelines from the CDC. So I think something that is really important, although it won't change our practices, is it shows that spread from touching surfaces is not a really true common way. So if you touch a surface that might have some virons with your hands and you stick it in your mouth, which I wouldn't do, but we find that to be a less effective means of transmission. So droplets, yes. Respiratory, yes. Some aerosol transmission, yes. But the touching of the surfaces really has dropped down. Will that change how I manage my waiting room? And the answer is no. I'm still not going to have any paper. I'm still going to be wiping down all of the surfaces on a routine and regular basis, including door handles, including magazine stands, including chairs, trying to get my waiting room chairs that are seamless so we don't have any virus or any kind of pathogens hanging out in the seams. And so we still are going to maintain that because, as I've said, we have a lot to learn about this virus. So also our routine dental infection control standards mean we're wiping down all of the hard surfaces, and it's really truly important to follow manufacturer's instructions so you have the proper wet time to kill the pathogens. So for instance, the new purple top that we are using on a limited basis in my facility actually has a wet time of 1 minute, which is pretty remarkable. Used to be 2 minutes, and you have to make sure that the surface stays wet according to manufacturer instructions used for it to be effective. And I think that's very important. So there isn't one solution that fits all. We have different kinds of offices. We have open bay offices. We have closed door offices. What can we do to limit transmission? And apparently we've been doing a very good job of it. So there can be source control, which is important. Ventilation is important. And of course, cleaning the air. And these are source control I think we've been doing for years. We just didn't realize it. Ventilation, we've been doing a part of it with high volume evacuation, but air cleaning, I think in most dental settings outside of hospitals is something that's new for us and that we're learning about. So in aerosol and aerosol management, the first is source control, rubber dams. Something that I learned in dental school and my brother before me learned in dental school and we're still learning in dental school is the importance of rubber dams for patient comfort, to maintain control of our aerosols, etc., and also high volume evacuation. Again, that's very important in keeping the saliva count down. I think it's very important that my hygienists have access to high volume evacuation. They have access to extraoral evacuation, and that we're doing our best to make sure that we're cleaning the air. Ventilation and local and centralized. So our ventilation, you can see several examples of extraoral evacuation. As someone who has a wonderful dental assistant, I can remember years back where I would be doing a complicated procedure and she would be doing excellent high volume evacuation. But when I looked at my shield, because I've been wearing a shield since I started, I could see that there were droplets on the shield. And so now I'm more comfortable, even if there wasn't SARS-CoV-2, I'm more comfortable having this extraoral evacuation system to make sure that everything is getting trapped. And so one of the tests we're looking to see our effective use of extraoral evacuation is checking the shields post-procedure to make sure that they remain clean. And I think that's been one of our better ways of following this. You also need to look at your airflow. How is the air flowing within your program? So when we talk about HEPA filters, we want that on the patient's feet. We want to make sure that we're not having the airflow come at the provider and the patient. We want to make sure we're following a good direct route of airflow. And in my case, I told you I'm building a new facility, and in that facility, looking at the airflow for the safety of the patients, providers, etc., has been one of our number one concerns. And I am not an HVAC expert, so I had to bring in help for that. Air cleaning. There are some since I've been starting this in March, I have looked at all of these different air cleaning devices. There are some remarkable systems. If you have a new HVAC system, going for a centralized form is a wonderful way of doing it, putting HEPA filters in there. When I actually talked about the extraoral aerosol devices, I'm a big fan of having multiple ways of trapping and killing the virus in one device. I actually think that's an advantage if you do have HEPA filter within there, charcoal filter within there, MERV filter within there, layers upon layers, and possibly UVC as well. I think the more we do, the better we're going to be. And so air cleaning, it's the same thing. We want to make sure we can have some laminar flow. We want to have one pass kill rate. We want to do what we can to make sure that we're cleaning the air as efficiently as possible. We also need to look at air exchange rates. For my new program, we're going to have an air exchange rate of 15, which is what we do at the hospital. If you've been watching about air transportation, the airplanes actually have been doing this for some time. They have an air exchange rate of 20 per hour, which is more, and they actually look at the flow to make sure that it goes down and around. So there are several things that we need to do to protect. I think many of us are doing them and are learning about them, and it's how we are addressing our aerosol concern. What did happen? We had this virus break out in Wuhan, China, and there are dental emergency facilities there. The dental teams at the oral medicine hospital in China did not develop COVID-19 while providing emergency dental treatment during the pandemic, likely due to increased infection control measures, according to a study that was actually published in the Journal of Dental Research, the AADR journal. Comprehensive measures such as the use of advanced personal protective PPE equipment and environmental disinfection can prevent cross-contamination in dental practices. And I think that is wonderful news. So none of the dental practitioners in Wuhan, China, seroconverted. Handpieces and ultrasonic dental instruments, as we know, create a presumed risk of infection in the dental practice. Dental hygienists, who are very important to our practices, are very important to our team effort, and are important to keep our patients healthy, have been labeled as most risk for these reasons, which is why I explained why I have high volume evacuation for them and extraoral aerosol vacuums as well, and HEPA filters in each of their rooms. I have an older HVAC system in where I'm my present location, so I chose to use portable units until I get up into my new facility, which will have a brand new HVAC system, and then I will go to a centralized model. Dental teams have stockpiled PPE when we can get it, and that has been an issue. We've spaced out appointments to provide more time for cleaning. We've adhered to social distancing guidelines as best as possible. And despite these measures, some oral health care professionals and patients have been hesitant to come back. I think the more we communicate with our patients on the efforts we're taking to provide them with a safer environment, the more willing they will be to come back. And I have some excellent news on what people polled think about returning to the dental setting in a few minutes. There was another study that came out. So this is the second study. This was based on when Italy had its explosion. Remember, there was a mutation in the virus when it came to Italy to make it more contagious, not necessarily more pathogenic. It's not more a severe disease. It's just more contagious. And that's the virus that we're dealing with here. Public health dentists and dental assistants in Italy who treated the patients during the COVID-19, their big burst of COVID-19 pandemic, did not appear to develop the disease, according to an article published in Oral Diseases. And that study, the occupational risk of dentals and dental assistants getting COVID-19 was estimated to be 0 when followed basic infection control guidelines. Now, we're not following basic. We are actually taking it to the next level where we are actually doing HEPA filtration, air filtration. We're doing the extraoral evacuation and making sure that all members of our team have access to high volume evacuation. Going back to the study in Italy, 320 staff members at their hospital of stomatology provided dental emergency treatment, including apical periodontitis, impacted wisdom teeth, and tooth fractures to over 2,000 patients during this outbreak. Between January 23rd and April 7th, dental healthcare workers wore advanced PPE, including N95s or KN95s, respirators when available, and maintained equipment and environmental disinfection measures. None developed COVID-19, according to the authors. Though the study may help clinicians and teams at ease, it had few limitations, and it's always important to bring up the limitations in a study. It was based on retrospective data, so what people had reported. This may have led to a little bit of recall bias. I don't remember having it, or I might not have felt good for a few days, but still no transmission that was documented. I think one of the most important things are, what do our patients think? So there was a poll that came out by the Delta Dental Institute, and U.S. patients are prioritizing oral health to COVID-19. Nearly 3/4 of patients in the United States believe that routine dental appointments remain important during the pandemic, and that the benefits of going to the dentist outweigh the potential risk of delaying preventive care. And I think that is very, very important, and that data is recent. Most patients responded they not only believe the benefits outweigh the risk, but also worry about the negative long-term health consequences as a result of delaying appointments, according to the survey. I think we've done a really good job of telling people that you can't be healthy without oral health. I think people have developed a routine. They want to see their dentist. They want to get their teeth cleaned. We know people, when they have emergencies, want to come in, but we still have some work to do, and that is through marketing. And I'm not a marketing expert, but it's communication. And we've talked about how important communicating to our patients and our communities on the steps we're taking. Even if you have an unfortunate incident, and there was an unfortunate incident in a dental clinic where someone was on vacation, came back with COVID, and some staff members in a small area also got COVID. It wasn't related to dental procedures, but what they did was they closed the practice. They put the staff members in quarantine, made sure they got the care they needed, were upfront to their community and upfront with all the steps they took. So they got a bad situation and made it a better situation by coming and telling folks, this is what happened, but based on A, B, and C, all the different steps that we're taking, once we reopen, it will be safe to come into the office. And I think when you have a situation like that, or even if you don't, if you communicate that you are going the extra mile, people will respond positively. So there is also the CDC and NIH vaccine distribution framework came out, and it categorized that dental healthcare workers are essential, which we know, but it's also good to know that other people know. So we'll be towards the front of the line when it comes to an effective, safe vaccine. And that's important because we have to have an effective and safe vaccine. And that's why you're seeing, even though the 2 of the 4 trials have been temporarily halted, they're doing the research and to find out what happened out of all the people that are in these trials and what we can do to prevent it. So the NIH and CDC outlined COVID vaccination allocation framework and identified dentists and dental hygienists, and I will say all members of the clinical dental team, as essential healthcare workers who should be given early access, according to the American Dental Association News. We are thrilled that the national academies have affirmed what we've known, and you can see the names there. The respective president and executive director of the ADA told ADA News, dentistry is an essential healthcare service, and dentists and their teams are essential healthcare workers. I've been in the front lines of HIV since the 80s. We've known that here. Now we have greater research showing the benefit of oral health to all people in our country, all people around the world. And so we have to be vaccinated. We've taken extra measures for control, and that's why we don't have any documented cases of transmission so far in the dental setting. To me, something that is remarkably exciting, because I work in a medical dental integrated model. I work with primary care providers. I work with a Women, Family, and Children's program. We're constantly trying to tell our younger patients to get the HPV vaccination. Actually, they've changed those ages up higher. So we're used to telling people about vaccines. And I don't want people to get the wrong idea. Vaccines are where we need to go to prevent COVID, to get our lives back to normal. So the American Dental Association, in consultation with the Advisory Task Force on Dental Practice Recovery, released a COVID-19 and lab testing requirement toolkit to help guide dentists interested in offering their patients rapid response, point of care COVID-19 testing within their practices. There are so many people who come to see the dentist in the course of a year who don't see a primary care provider that we can actually offer them to be tested. And I think that is a fabulous step that's moving forward. And I think that you'll find this to be useful. The toolkit includes information on applying for federal certification to offer COVID-19 testing. This is called a CLIA waiver. And in the future, we'll go over that a little bit more. While rapid point of care testing is not widely used currently, as the technology and access to the important tests improve, the comprehensive document will enable members who want to do testing in their offices to be sure they're compliant with all regulatory guidelines. And one of the most important things when we take this on is if we do have a positive, we have to actually report it. We actually have to report negatives as well. And so we have to find effective uses of our time, but also great service to our community. And I think that is a wonderful thing that the ADA has done, and something that we will be talking about in the future, because being able to test our patients is an extra benefit. And I think it will help us get this disease under control and get our lives back to normal sooner rather than later. So again, thank you for your time and attention. I know this is a lot of information, but it was my pleasure to share it with you. Be sure to have any questions that you want, and we'll try to answer them on Friday. So again, thank you for your time and attention, and back to Gary.
Thank you, Dr. Reznik. Great to hear from you again, and certainly all the great information, especially reminding offices to check their airflow in their office, as well as air purification systems if needed. Also, thanks for the reminder for everybody to get their flu shot this season. If you have any questions, concerns, or comments, please email us at webinars@henryschein.com. And please subscribe to our YouTube channel by clicking the subscribe button below. Again, I'm Dr. Gary Severance with Henry Schein. Until we see you again, or till next time, stay safe and stay informed.